Hello, I'm Dominica. I am a paramedic student and I'm in methods of teaching. This is my presentation on retrograde intubations for my final project. Goals and objectives. Lesson goals. After completing this lesson, the student will be able to define what is a retrograde intubation. The student will be able to identify those indications a paramedic may use to go ahead and perform a retrograde intubation. And at the end of this lesson, the student will be able to explain the risk and benefits a patient may be posed with when having a retrograde intubation. Lesson objectives. The student will be able to identify scenarios in which retrograde intubations may be used to establish a definitive airway. So, before we get into actually learning about retrograde intubations, I wanted to take this time to integrate the listeners and the viewers into this learning experience, and we can interact in some review questions. So, if you have any paper and pen, you can answer the questions along with me. Just pause the video before we get to the answer and just write what you think the answer may be, and let's compare notes and see how we do. Okie dokie. First question: what is a definitive airway, and when do we need to establish one? So if you have your pen and paper, you can pause right now, answer what you may think the definition of a definitive airway is, and when we need to establish one. And then when you're ready, you can just play the video, and hopefully you didn't see the answer already. But a definitive airway is defined as a tube that's placed in the trachea with the cuff inflated below the vocal cords. And as paramedic students, we learn that we intubate when we see that the patient is failing to oxygenate, the patient may be failing to ventilate, the patient is failing to maintain that patent airway, they can no longer protect their airway, and when we anticipate that this is the clinical course of that patient's condition. So examples include the failure to oxygenate. You may see exacerbation of COPD, exacerbation of congestive heart failure, or patients that are in respiratory failure and their O2 saturations are below 92, and they have these clinical signs of respiratory failure. You would want to intubate those patients. Patients that are failing to ventilate, they may have airway obstructions. They may are having spontaneous laryngospasms. You may have a burn victim and you see that they have singed eyebrows, singed facial hair, eyelashes may be missing, and you suspect that their airway may have been introduced to a whole bunch of heat and may be burned. These patients may end up having a hard time ventilating due to those compromises. Even anaphylactic patients or patients with low tidal volumes, these patients may be experiencing a failure to ventilate and need to be intubated. Patients that may fail to protect their own airway and may fail to maintain a patent airway would be those that are unconscious from possible overdoses, a closed head injury, alcohol toxicity, any acute changes in mental status. If you have a patient that has a GCS of 8 or below, you should consider, intubating. And then again, when you anticipate that my patient's condition will eventually deteriorate into needing a definitive airway, you should prepare to consider intubating your patient. So the example of the burn patient, they may present to you with a patent airway right now because you suspect that burn to the airway from all that heat that they were introduced to, and the singeing of the eyebrows, singeing of facial hair, and all of that, you anticipate that that airway is going to swell. And if you wait until that airway swells, you're going to be faced with a difficult airway, and it's going to be harder to establish that definitive airway right then and there. So these are when you should intubate. The next question: what are some known types of definitive airways? So for me, this was a little tricky question. Even though I wrote it, I was getting it wrong until I went back and I looked at that definition of what is a definitive airway, and that really helped me get an understanding of what are just artificial airways and then what are definitive airways. So pause, write all the answers that you think it may be, and then you can resume the video whenever you're ready. The answer is endotracheal intubations and nasotracheal intubations. So these intubations include an endotracheal tube passing through the passing through the larynx, cuff past the vocal cords and into the trachea to establish an airway. I know initially I put needle Craig and surgical Craig on there as well, but after I considered that definition and the requirements of a definitive airway, I noticed that the needle Craig and the surgical Craig, they did not meet those requirements of having that tube enter into the trachea and a cuff past the vocal cords. So I hope you guys enjoyed the review and it got your brains thinking, and now you're all ready to learn more about airway management and retrograde intubation. So that's exactly where we're going to start, and we're going to establish what is a retrograde intubation. So a retrograde intubation is an alternative method of establishing a definitive airway in patients with difficult airways when blind nasal intubation fails and fiber optic bronchoscope is not available. It is a technique that is actually a translaryngeal guided intubation, but for historical reasons, the person who created this modern method of intubation described it as a retrograde intubation. So we continue to call it a retrograde intubation because that's what he decided it should be named. As I was doing the research, I continually saw fiber optic bronchoscopes, and I didn't know what it was, so I just wanted to include this image to show anyone who didn't know what it was. This is a tool. It's used in the hospital setting and in surgical settings, and it's not really used in a pre-hospital setting, but this is what it is, and it's for intubating and visualizing the airway. And I wanted to refresh those listening on the larynx, because this is the main anatomical structure in the procedure of a retrograde intubation. So here we have the posterior view of the larynx. You see the epiglottis, you see the hyoid bone, you see the thyroid bone, you see the trachea down here, cricoid rings. In the anterior view, again, the thyroid bone, hyoid bone, you see the cricothyroid membrane, and the cricoid right there. And in the lateral view, you have the epiglottis, you have the hyoid bone, thyroid, cricothyroid membrane right in there. And here you have the superior view. So here are the muscles of the vocal cords, and you would pass your endotracheal tube right here, right between the vocal cords. So this is the larynx, and this is a structure that we really do have to be familiar with when performing a retrograde intubation. A little more on what is a retrograde intubation. Retrograde intubations require a non-surgical translaryngeal airway access to guide the oral tracheal or nasotracheal intubation. So this airway access is usually accomplished in a procedure that's similar to a needle cricothyrotomy. Retrograde intubations can be used in both awake and apneic patients when other methods have failed. Tracheal intubation by means of a guide. It is a tracheal intubation by the means of a guide introduced in a retrograde manner from below the vocal cord and brought out through the mouth or the nose. And this method of intubation is an alternative non-invasive technique used in difficult airway algorithms, and it is recommended by the American Society of Anesthesiologists and the Canadian Society of Anesthesiologists. I did want to just return to the previous image because repeatedly we've seen the phrase translaryngeal guided intubation, and that may sound like a new term, a new phrase, an unfamiliar term, but it really is something that we're already familiar with if you're familiar with oral tracheal intubations, especially if you prefer the use of a bougie. So when you use a bougie, you are basically performing a guided translaryngeal intubation, because that bougie is going to enter through the oral pharynx, and it's going to enter into the larynx and pass through the epiglottis, pass through the vocal cords, into the larynx, down into the trachea, and you're going to feel it touch the cricoid rings, and you know you're in the trachea, right? So then you have that bougie in the trachea, and you take your endotracheal tube and you pass it over the bougie, and now the endotracheal tube is passing through the vocal cords into the epiglottis, down into the larynx, and it's going to stop in the trachea. You inflate the cuff, and there you have guided that endotracheal tube across the larynx, and you have established that definitive airway. And that's basically what the retrograde intubation is as well, but in the opposite direction. And for the retrograde intubation, it's a guided translaryngeal intubation. So in the cricothyroid membrane, you introduce your guide, and it's similar to a bougie, a little thinner, but it does the same job. You enter your guide in the cricothyroid membrane, and wake up my mouth. It goes up instead of down. It goes up into the larynx, up through the epiglottis, past the vocal cords, up into the oral pharynx, out of the mouth. We'll use the mouth for the example. And now you have your guide out of the mouth, where you can get your endotracheal tube, and similar to a bougie, you pass it over the guide, and now the endotracheal tube just follows the guide down the epiglottis, past the vocal cords, into the larynx, and then since it's past the vocal cords, you can inflate the cuff, and you have access to the trachea. So it's similar to that, just in the opposite direction. If that wasn't clear, we will have a video a little bit later. We will have step-by-step procedures and how to do it, but it is a fairly simple in word procedure, but the physical task is where you need that skill. What is the indications of retrograde intubation?